So good morning, everybody. My name is Tuesday Werner. I'm a nurse practitioner at Mayo Clinic Arizona. I've been working there for over 20 years, and I have an invitation to discuss about NITs or non-invasive testings, a practice overview, and navigating the basics for patients with MASLD and MASH. And this program is through the GAP MASLD MASH Community Network. So there's several questions here with regards to NITs. So the first question is, explain the fundamental experience between simple steatosis or MASLD, Metabolic Associated Steatosis liver disease, and MASH or Metabolic Associated Steatohepatitis, and why distinguishing between them using NITs is clinically significant for patient management. So in addressing this question, first we have to do the definition. The MASLD or simple steatosis basically is less than 5% of hepatic fat accumulation, and there's no significant hepatocellular injury or inflammation. It's often stable, lower risk of progression. On the other hand, MASH or metabolic dysfunction associated steatohepatitis, this is steatosis plus hepatocellular ballooning and inflammation. MASH can progress to fibrosis, to cirrhosis, and development of hepatocellular carcinoma. Now, the prognostic significance, like the fibrosis risk, steatosis alone is usually benign. However, MASH or with the steatohepatitis has inflammatory drives and also causing fibrogenesis. So the clinical outcomes with MASH with fibrosis is really higher risk of cirrhosis, liver failure, and also development of hepatocellular carcinoma. MASLD without inflammation basically have lower liver-related mortality, but still have higher cardiovascular risk. So the role of non-invasive tests or NITs is really to prevent any of the invasive approach, such as liver biopsy, which is also very invasive and very costly and not scalable. NITs help distinguish this risk using the FIB4, which is we use for initial risk stratification, elastography or FibroScan. We use that to detect fibrosis, and anything greater than F2 is significant. There's ELF tests, there's MRI, PDFF, and serum biomarkers, which also add precision. Now, the clinical significance of NITs is that it identifies patients with MASH plus fibrosis and who need closer follow-up, hepatology referral, and possibly use of pharmacotherapy. It also avoids burdening the system with unnecessary referrals for low-risk MASLD. So really the teaching part of this is that distinguishing MASLD versus MASH, it's not just academic, but it's directly guides who needs hepatology referral, advanced testing, surveillance, and also use of emerging drug therapy. So the second question is that compare and contrast the commonly used serum-based NITs, such as the FIB4, NFS, and ELF, versus the imaging based NITs, such as the VCTE or FibroScan and MRE. So compare it in terms of accessibility, information provided with steatosis versus fibrosis, and limitations. So let's start with the serum NITs. Serum NITs such as FIB4, NFS, and ELF. The accessibility is there. It's simple labs. It's inexpensive and widely used even in primary care. The information provided by serum-based NITs includes fibrosis risk stratification, either low, indeterminate, or high. And the strength is that it is easy to calculate and good for first-line screening, and it's scalable. The limitations, however, there's these gray zone results affected by age and comorbidities, and there's no steatosis information. On the other hand, imaging-based NITs such as VCTE or FibroScan and MRE, the accessibility of this is that it's available to hepatology centers. MRE is costly and limited to tertiary centers only. The information provided, however, with this imaging-based NITs is that there's a fibrosis staging with the stiffness, steatosis quantification measured in CAP or MRI PDFF. The strength is that imaging NITs is more precise with fibrosis assessment. It is non-invasive, and of course, there's biopsy sparing. Limitations, FibroScan is less reliable with obesity or if the patients have ascites. MRE is expensive and, of course, less available. So really, serum NITs, it's the first line gatekeepers and really for patients who needs more workup. And imaging NITs, it's like the referees. It confirms or clarifies the fibrosis stage and also guide us for a referral. So how about this third question? How do you integrate NIT results into the overall clinical picture, including comorbidities, LFTs, and patient history, to make these informed management decisions regarding monitoring frequency or referral? So integrating NITs into clinical decision-making basically have several parts. So first, you start with the patient context. You look at their comorbidities. Are they diabetic? Are they obese? Is there any hypertension or dyslipidemia? You consider their lifestyle factors. How about alcohol intake or diet and their exercise patterns? Their family history, any history of cirrhosis or liver disease or history of hepatocellular carcinoma or liver cancer in the family. And of course, check their medications, looking at use of statins or any hepatotoxic medications. Then you look at the lab assessment. You look at liver function tests, AST, ALT, alkaline phosphatase, bilirubin, albumin, INR, and platelets. And then you look at the pattern. Is there persistent elevation with ALT or any concern for MASH? And look at the platelets plus the AST and ALT, which feeds into FIB4 and NFS. And then you apply NITs sequentially. So you look at the serum NITs, FIB4 or NFS. If it's low risk, you reassure patient and then you monitor every 2 to 3 years. And if indeterminate, you proceed with the imaging NITs using FibroScan, MRE, or ELF. So usually if it's less than 8 kilopascal, which is low risk, you monitor. And then if it's 8 to 12 kilopascal, it's a moderate risk. So closer monitoring, possibly hepatology referral. And if it's 12 kPa, kilopascal or more, it's high risk and hepatology referral and maybe consider biopsy and as well as including surveillance with the management. And then you integrate all this and individualize. So patients who are young and healthy with MASLD, normal LFTs, they're considered low risk. We monitor them every 2 to 3 years. If they're diabetic, they're obese, and have indeterminate FIB4, as well as FibroScan, which is greater than 9 kilopascal, you monitor annually or refer to hepatology. And then if the patient with high NITs, abnormal LFTs, and there's cirrhotic signs, there's a stigmata of physical exam, stigmata of liver disease, then urgent hepatology referral, and then consider hepatocellular carcinoma surveillance as well as variceal screening. So really, it all depends on these components and then decision making based on their low risk, their lifestyle focus, maybe PCP monitoring. If they're intermediate, you intensify metabolic management and closer follow-up and hepatology referral if worsening. And if they're on the high-risk category, hepatology referral, advanced testing surveillance, clinical trial, or maybe pharmacotherapy consideration. So really, NITs are tools, and it's not a standalone answers. Always interpret with the context of comorbidities, the labs, and history to decide whether to reassure, to monitor, or to escalate care. So then we'll go to the next question. What key thresholds APP should know for NITs like FIB4 or VCTE kilopascal values to stratify fibrosis risk and guide management pathways? So the key NIT thresholds for MASLD and MASH for, let's say, FIB4 or serum-based. So for the result of less than 1.3, it's low risk for advanced fibrosis. So monitoring is good, even in primary care. If the FIB4 is about 1.3 to 2.67, which is indeterminate, you proceed on imaging NITs with FibroScan, ELF, or MRE if it's available. And if it's greater than 2.67, which is considered high risk, refer to hepatology. With regards to FibroScan or liver stiffness, if the KPA is greater than 8, it's low risk, F0 to F1, and then monitor every 2 to 3 years. If it's 8 to 12 kilopascal, it's considered moderate risk, or F2 or F3, closer follow-up, consider hepatology referral. And if it's greater than 12 kilopascal, it's high risk, consider F3 or F4, advanced fibrosis, maybe / cirrhosis, initiate HCC and variceal screening or surveillance. Now, with regards to CAP score or CAP from the FibroScan or steatosis score of per decibels per meter squared, if it's greater than 274 decibels per meter squared, which is considered steatosis, S2 greater than 2 or S greater than 2, not prognostic, but supports the MASLD diagnosis. And then there's this ELF test. If it's greater or less than 7.7, it's low risk. 7.7 to 9.8 is considered moderate risk, and greater than 9.8, it's high risk for advanced fibrosis. So basically, the use of FIB4 to rule out low risk. And if it's low risk, you monitor. If it's intermediate zone, confirm with FibroScan or ELF. And then if it's high risk, hepatology referral, pharmacotherapy, and as well as HCC surveillance and esophageal variceal surveillance. So APP should remember that anything like FIB4 less than 1.3 rules out, greater than 2.67 rules in, and with regards to FibroScan, less than 8 is safe. However, greater than 12 kilopascal is worrisome. So this ends my topic for today. If there's any question, just visit this GAP MASLD MASH community network. And thank you for listening today.